Unless you want to do it, James. Cool, that should be recording. Great. Hi, everyone. Thank you for the introduction. It's always nice being introduced by people. My name is Dr. Stephen Naulls. I'm an academic clinical fellow based in the Department of Neurosciences at BSMS. I'm also a psychiatry ST1. For those of you that aren't medical by background, that means that I'm right at the start of my specialty training to become a psychiatrist. I'm not a radiologist and I'm not a radiographer. I'm quite new to neuroimaging, but I'm really excited to be working on this study with James. If there's any technical questions, Itamar might be able to answer them for you, but I will do my best in the first instance. So I'm here today to speak to you about a pilot study of brain imaging and a cohort of people that are involved in something called Chemsex. Can I just get a show of hands before I go into the presentation? Who is familiar with that term? No. PI's put his hand up. So quite a few people. I'm going to go into a little bit more detail about what Chemsex is, what it means, and the origins of the term right at the start of the talk before I get into like the nitty-gritty neuroscience. But I just wanted to start with a short anecdote about why I care about this, and also give you just a brief content warning about some of the stuff that we're going to speak about in the course of this talk. So I remember when I was a year 5 medical student, I went to university in London, and I just finished my psychiatric placement and decided that I wanted to be a psychiatrist, and that I was specifically interested in addiction psychiatry. And then I went from my psychiatry placement onto my A&E placement, and I was at a busy West London hospital. And I remember there was somebody who had been brought in with respiratory depression in the context of a GHB overdose. And I remember being quite surprised because I found that quite a lot of the doctors in the A&E department were quite dismissive of that patient. They referred to them as a frequent flyer, frequent attender. And because I just finished my psychiatry placement and I wanted to be a psychiatrist, they sent me to go and take a history from them and were just overall quite dismissive. I found it to be quite a negative experience. But actually, when I took a history from that patient, I spent quite a lot of time with them because obviously we like to do that in psychiatry. I actually discovered that they'd been engaging with this phenomenon called Chemsex for quite a long period of time. And that actually they had lost their partner through a GHB overdose. They'd woken up in bed one morning and their partner had a GHB overdose and died. What's GHB? Gamma hydroxybutyrate. It's a respiratory depressant. I'll get onto it shortly, but it's one of the medications that, one of the drugs that is used quite commonly in Chemsex. They died of it. Their partner died of a GHB overdose, and they still weren't able to stop themselves from engaging in Chemsex. And I thought to myself, if people arrive at A&E and they've got an opioid overdose, they've got alcohol addiction, we've got quite well-established pathways, but actually we have relatively little for people who are struggling with Chemsex addiction. And that was, 8, 9, 10 years ago now, and still I don't really feel like people are doing enough about it from a psychiatric perspective. So that's what I'm hoping we can achieve with this study. So what is Chemsex? So the definition that was adopted by David Stewart, who is kind of the god, I suppose, of Chemsex, is unfortunately not with us anymore, is the use of specific drugs used specifically for sex and specifically by gay and bisexual men who sleep with men. That's expanded more in recent years. We see quite a lot of Chemsex in the trans community and the non-binary community as well. But it's also the specific use of drugs like crystal methamphetamine, GHB or GBL, and synthetic cathinones, usually mephedrone. And those 3 substances together are referred to collectively as chems. And if you want to look into the history of where that term came about, I'd encourage you to read the review that is at the top of the screen, which was authored by David Stewart, who came up with this term, Chemsex. But effectively, historically, where the term chems comes from is when queer cultures were driven underground, quite often due to homophobia, transphobia, and they had to have their sex in secret. And when they were trying to facilitate their sex through the use of drugs, which people have obviously done for hundreds of years, thousands of years, the term that they would use to kind of refer to that discreetly was chems. So when people were looking for drugs to use during sex, they'd refer to them as chems, and that caught on. And we know that these 3 chems in particular are responsible for most of the harms associated with Chemsex. So GHB comes with a very high risk of overdose because of respiratory depression. Crystal methamphetamine has a high risk of psychosis, independently associated with risk of psychosis because of its effect on the dopaminergic system. We know less about mephedrone, but it can lead to feelings of paranoia. But also, when people are doing Chemsex, they're not just using these 3 substances, they're often combining it with other substances, so poppers, alcohol, Viagra, cocaine, ketamine. I put ketamine in italics because the specific kind of high that people are chasing with chems use methamphetamine, mephedrone, GHB, is often a disinhibitory or a dissociative state that in some cases can help them overcome aspects of minority stress that might have been brought about by, for example, growing up in a small C conservative background and overtly religious background where they didn't feel comfortable with their homosexuality. But we know that ketamine obviously it's referred to as a dissociative, so it can also bring that about. And actually, I don't really think that this definition of chemsex and referring to 3 specific drugs in particular is that useful, but unfortunately in the literature, that is the way it is defined right now. So that is the definition that I am giving you for the purposes of this talk. And if I'm able to develop any kind of profile in this research area in the future, I probably will challenge it, but that's what we've got to go with for now. And just to drive home that distinction between what we refer to as chemsex versus sexualized drug use, as I've said, people have been having sex for thousands of years, people have been using drugs for thousands of years, people have been doing them together for thousands of years. But what distinguishes chemsex specifically from sexual drug use, and again, this is in the review article that David Stewart authored before he sadly died, is the link that it has with some of the historic issues that queer people have faced. So there are a lot of older people who are engaged in chemsex, and quite a lot of them will speak to you about the trauma that they've experienced as a result of the AIDS epidemic in the 80s and 90s, a feeling that they struggle to be able to engage in sexual activity with people because of that trauma in the past, and also a sense of loneliness because lots of the people that they grew up with unfortunately died, and it's a sense of them being able to get connection with their community. There's also increasingly this issue of LGBT or queer-specific rejection with the advent of hookup, so Grindr, Scruff, etc. Where particularly for gay men, you can open up your phone and on a geolocation app can have access to sex very quickly with somebody like 10, 15, 100 meters away. And also the advent of quote unquote high and horny party and play adverts on these apps, which facilitate that access to sexual activity, chemsex, via the apps, which makes this so much easier for people to get access to. So in terms of the 3 chems in particular, what do we know about them? Well, the one that we've got the strongest evidence base for, and the one that has the most, I suppose, the most reproducibility, is methamphetamine, which also you might have seen referred to as T or Tina. People often refer to a triangle in South London as the Tina Triangle, where there's lots of people who are experiencing harm as a result of crystal methamphetamine use. And we know that meth has a very pronounced effect on the dopaminergic, serotonergic, and noradrenergic pathways in the brain. And in the short term, you might see increase in particular in dopamine release in the mesolimbic pathway and in the striatum, but that also over long periods of time, that can lead to aspects of neurotoxicity that might damage dopamine structures there. Jumping down to GHB, we know from studies that it has, so to answer your question, it's a GABA B receptor agonist. And GABA being an inhibitory neurotransmitter, so it can lead to feelings like sedation, feelings of calm for people who are engaging in it, but also it has a biphasic effect. So at small doses, it might lead to inhibition, and then at higher doses, increased release of dopamine. We know comparatively less about mephedrone. Quite a lot of the studies that have been done with mephedrone have been done in animals, but there are some studies in humans suggesting that there might be some changes in the hippocampus and the beta ganglia. But what we do know is that it also acts on the dopaminergic system. And I've highlighted in bold on the right some of those risks that I mentioned earlier. So risk of psychosis, paranoia with mephedrone, and a high risk of overdose with GHB in particular, which is what has got chemsex in the news quite a lot recently. But it's not just, and I'm not encouraging you to read all of this slide, don't worry, because obviously it's there by text. But the thing that I wanted to pull out again from this article from David Stewart is it's not just about the specific use of those 3 drugs, it's about the combination of those 3 drugs, the combination of other drugs, and the additive effect of sex. So we know a little bit about, well, we know quite a lot about methamphetamine, but we know how those drugs individually affect the brain in various ways. We don't know the effect of the polysubstance use and also the combination of the polysubstance use with the additionally dopaminergic activating activity of sexual activity. And so I just really want to like drive that home and put that together for you now. So we've got chems, which is methamphetamine, mephedrone, GHB, and they can be used in any combination together. For example, in Brighton, in the sexual health clinic, we know that we have a high proportion of people who attend the chemsex services who use methamphetamine, but actually where I moved from recently in London, and there was a high proportion of people using mephedrone. So there might be a mixed picture across the country. So there's already a kind of uniqueness to the mix that people have there. But then we know that people are combining chems with other drugs, and Viagra, poppers, cocaine, ketamine, alcohol, MDMA, you name it, people are probably combining it with those substances. And so you could probably say that on an individual level, there might actually be numerous people with quite a unique profile of substances that they're using. And these are all very potent, powerful drugs. But then we combine them with the sexual activity as well. And that is when we get to chemsex. And people can be doing this in pairs. People can be doing this at group parties, which are lasting for several days. And also people could be doing this in gay saunas and also in dark rooms, in nightclubs. If people don't know what dark rooms are, it's a place in a nightclub where sexual activities are allowed and sometimes encouraged. And there's high levels of drug use in those areas as well. I published an article with James, Jess, and with some colleagues at Imperial earlier in the year about some of the risks that might be associated with the specific use of drugs in sex on premises venues in the nighttime economy. So hopefully I've convinced you somewhat that it's not just about those individual drugs, and it's about the polysubstance use in combination with sex. Now, in terms of what we know about how that affects the brain, that combination of those three things together, we know comparatively little. There's not been any MRI studies that have done in the world looking at the unique combination of those three things. The closest that we have is this EEG study, which was published last year by a group, I think in Germany, towards the end of the year. And they, as I said, used EEG. You could argue that that's neuroimaging. James and I don't think that is neuroimaging, to assess evoked potentials while people were doing a go, no-go task. And effectively what they argue is that they found reduced N2 amplitudes in central regions that they think could be representative of impaired decision-making and impaired inhibition of responses in the chemsex cohort. I've got to be honest, they only recruited about 40 people to this study. About 12 of them didn't understand the task well enough to be able to complete it. So the original power that they'd set up was actually quite undermined. And so whilst they did find in the voluntary selection component of the go, no-go task that there were significant differences between the N2 responses in the chemsex cohort versus the control, it only trended towards that in the no-go. They argue in the paper that's probably because lots of people had to be excluded from the analysis. I'm not so sure because, for example, they didn't match according to handedness, they didn't control for HIV. Yeah.
Can I interrupt with a quick question? So what kind of control group is it? I mean, you can think of many different controls, right? I mean, you can have people that have sex addiction without the chemicals, or other way around, or people that are naive to both.
So in our study, or in their study in particular?
In this study, for example.
In their study, it was naive. So they didn't have people who were using any of the three main chemsex drugs. Does that make sense?
Yeah, I mean, it makes sense.
But
From the experimental perspective.
they didn't control for HIV status, they didn't control for handedness. I think they had three people.
What's the size of the population that they, how many roughly?
They recruited 40, but they only included 25. They recruited 43. Originally 23 in the chemsex group, 20 in the control group, and then because of dropouts and issues in the course of the analysis, it became 15 chemsex and 14 controls.
And the traces that we see here are averages over the traces of the control, without error bars. Just
I don't think it's a fantastic paper, but it's all we've got. I'm just presenting you.
Just to see who are the adversaries that we are
having. I'm presenting you what we've got focused specifically on chemsex, because people have looked at the drugs narrowly individually, but they haven't looked at it in the sexual context, and they haven't looked at it with this nature of polysubstance use, which is unique to the chemsex cohort. The fact that this is all we've got and this term's been around for 15 years, I think speaks to some of the stigma that these people are experiencing. The other thing that we have is some review articles looking specifically at chemsex and aspects of mental health. So this is chemsex and psychosis. And really what I wanted to draw your attention to here is obviously the high levels of substance use or dependence that's prevalent in this population. And also kind of a nod towards the right-hand side about some other work that we might be doing in the near future about possible involvement of ADHD in this. And I suspect that there probably is an overrepresentation of people with ADHD in the chemsex cohort. We know that if you if you're neurodivergent, you're already at an increased risk of substance use disorder. And I suspect that's probably going to be the case with the chemsex cohort as well. Yeah.
Could that partly be because amphetamines are prescribed to people with ADHD?
Yeah, it could be.
Like substances. So
It could be. It could also be. It could also be that people, as a means of coping with their symptoms of ADHD before they're diagnosed, they're using amphetamines, and sometimes they're using them in a sexual context. We don't know. Nobody's done the study looking at how ADHD could be correlated with chemsex, but we do know that there's an overrepresentation of people living with HIV, people with ADHD in generic substance use disorder cohort. But the thing that I particularly wanted to draw out about this study is obviously we've got the 3 chems on the left-hand side, which are the most commonly used. Again, to drive home my point that I think that this definition, loosely based on it being these 3 substances, is probably flawed. Looking at the ranges that I presented here, actually, you could argue that cocaine is a chemsex drug because it intersects with the others. So I don't really think that this definition is particularly helpful, but it's the definition that we use in the literature. However, what I do think is useful to see is the figure on the right-hand side, which shows the levels of, again, polysubstance use and also slam sex. Anyone know what slam sex is? So again, it's just the term slamming or slam sex refers to the use of IV drugs during sex. And actually in chemsex, again, we have a relatively high proportion of people who are using IV drugs during sex to facilitate their sexual encounters. And again, if you imagine methamphetamine, these are really powerful drugs, but particularly when you use them intravenously, it's going to be really enhanced effects. This is just a narcissistic opportunity for me to plug one of the papers that I published recently. I just wanted to bring that because I think that there's this narrative in the media in particular that this is like quite a hedonistic activity. And I kind of wanted to pull out more granularly, I suppose, some of the risks that these people are being subjected to. And so this is a quote from one of the participants that was involved in the publication that I had earlier this year about the use of drugs amongst LGBT people in sex on premises venues. And they mentioned that there's quite high levels of sexual abuse in people who are engaged in chemsex, partly because of the dissociation, partly because of the sedation, but also because of covert use of things like GHB being put into lube. It's a colorless compound, it's flavorless, and so it's quite easy for people to be spiked. It's also quite easy for people to overdose. And so quite a lot of the harm reduction advice that gets given to people is about dosing your own G, setting timers, etc. And really, I just wanted to kind of drive home for people that actually people are putting themselves into quite vulnerable positions here. And I know that they've been painted as being quite hedonistic in the media, but actually there are some people who are being taken advantage of, and they need our help. The other thing that I wanted to draw attention to just before I move on to the minutiae of the study itself is again how long this has been around for. So on the top left, you can see my Google search, chemsex, GHB deaths, and you can see that it's going all the way back to 2015. These have been being reported, but still actually in deaths where overdoses are suspected cause, GHB still isn't routinely checked for in all cases, even though we've got good evidence to suggest that in metropolitan areas like London, Brighton, Manchester, there are lots of people who are encountering harm as a result of GHB. And then just before I move on to the study, I would recommend, if you're interested in chemsex, to watch this documentary, Chemsex Beyond the Myths. It was published in March of this year, and has some really good interviews with people speaking about some of the chemsex specific harm, particularly in London. And I think they did an interview with an A&E doctor there at King's College Hospital, who said that 1/3 of their overdose related presentations in the last 6 months were related to GHB. So that's the level that we're dealing with in some of our cities in this country. Cool. So our study is a pilot study where we're aiming to recruit approximately 20 participants. The population we're aiming to recruit is gay and bisexual men engaged in chemsex at least once in the last month and at least 3 times in the last 6 months. The reason for that is because we want it to be clear that people are frequently engaging in chemsex and also that they've recently engaged in chemsex. Unfortunately, in contrast to things like opioid addiction and alcohol addiction, there isn't a good scale to assess the severity of your engagement in chemsex and whether it's problematic or non-problematic. Hopefully, if I do a PhD in this area, that's something that perhaps we could look to develop. But for now, you have to kind of try to you'll see in the kind of the data that we're gonna gather, you have to get it from various different sources. There's no intervention, and our control is men who don't use drugs, and we're going to be measuring simple measures of variance, and I'll explain the reason for that now. And that's because obviously nobody has done a neuroimaging study before looking at chemsex specifically, so we don't have a basis from which to draw a power calculation. You could argue that you could look at some of the studies of, for instance, methamphetamine, mephedrone, GHB, but actually because of the unique pattern of polysubstance use, I don't think that that's going to be particularly reliable. So what we're trying to do with this pilot study in the first instance is to gather some data from which to develop a power calculation that could be used for a more authoritative study. So if you focus on the left for now, the data that we're going to be collecting is basic demographics, some validated psychiatric assessments, so PHQ-9, which is for depression, a GAD-7, which is for anxiety, the Barrett Impulsivity Scale, and also an assist questionnaire, which is a clinician facilitated interview that goes into detail about people's use of various substances over the last 3 months and previously in the past. There's also something called the Chemsex inventory. It was published by a group in Madrid, I want to say 1.5 years or 2 years ago. And it was their attempt to create, again, some kind of rating scale to determine the harm that people might be experiencing as a result of chemsex. We don't think it's a particularly good scale, but because it's there, I kind of want to prove that by trying to correlate it with our findings. So, for example, if we're able to demonstrate that there are significant differences in the chemsex group versus people who don't use drugs, it doesn't correlate with the CSI. Hopefully, we can encourage people to not use that, because I don't think it's very good. We might not be able to achieve that with the first study. That's kind of the goal, perhaps further down the line. And in terms of what we're going to be gathering in this study, we're going to be getting obviously basic structural images, some resting state fMRI. We're going to be asking the participant to engage in a stop signal task, and also doing some spectroscopy and a relatively new type of neuroimaging called neuromelanin MRI. And I'll go into more detail about those in the next few slides. But again, just to reiterate, the point of this pilot is to assess feasibility. Will people involved in chemsex come forward and happily engage in this trial, and also establish the basis for a power calculation? Because when we compare people engaged in chemsex with people who don't use drugs, one of the first things that people quite rightly say is, well, how do you know that it's the additional effects of sex and the polysubstance use that's responsible for those changes? How do you know it's not just the drugs themselves? So an ideal setup would be to have 3 arms: people engaged in chemsex, people using drugs but not in a sexualized setting, and then people who don't use drugs. And then you can use things like an ANOVA to explore differences, probably which is probably a better setup and better science. But obviously that requires more participants and that requires funding. And so the pilot study, we're hoping will be able to set up the basis for me to put in a PhD proposal to be able to fund that study. So yeah, a little bit more detail about the imaging that we're hoping to do. So a functional MRI to begin with, and we're going to be doing a task-based stop signal task. The reason that we've chosen that in this cohort is because we want to measure response inhibition. So like I mentioned before, often these parties will start and people will be there for several days. So they'll go there on a Thursday or a Friday night and they'll still be there on a Monday morning. And so we wonder if there's an element of response inhibition, stopping, I guess a stop signal task is designed to check somebody's ability to inhibit a response that is already in place. So we're interested to know if there'll be any differences in them versus controls there. And then also we're going to be gathering some spectroscopic data, specifically GABA and glutamate in the medial prefrontal cortex, which we know could be disrupted in certain conditions, and also in addiction with regards to impulsivity. And we're going to try to correlate that with the scores that we gather from people on the BIS, the Barrett Impulsivity Scale. And then finally, the neuromelanin MRI, which is effectively a proxy for dopamine system integrity, which I'll speak about in a little bit more detail in a moment. And then just to go into a little bit more detail, our regions of interest. So like I've mentioned, the medial prefrontal cortex, the striatum, the anterior cingulate cortex. James and I have been speaking about this a little bit. I think we're going to go with pregenual anterior cingulate cortex. And then for the neuromelanin MRI, the VTA and the substantia nigra. So just to introduce a little bit about NM-MRI, as it's referred to. So it's a type of, again, it's its use in addiction and substance use disorders is relatively new, but it's been used quite a lot over the last decade or so, looking at Parkinson's disease. Neuromelanin is a byproduct of dopamine metabolism, and it forms paramagnetic complexes with iron, which show up on T1 MRI as a hyperintensity. And that's been used to look at the substantia nigra in patients with Parkinson's disease, to look if there is effectively a reduction in the hyperintense signal. Obviously, if it can be used for one disease that is grounded in dopamine dysfunction, it follows that it could be used in others. And so there's increased interest in its use in psychotic illness and also in addiction. And if you're interested in finding out a little bit more about neuromelanin, this is a link to a review article which was published last year. It summarizes some of the, I guess, the biochemistry of how dopamine and choline, norepinephrine, noradrenaline become neuromelanin, and then how that binding with iron complexes shows up as paramagnetic complexes that you can see on MRI imaging. The only caveat that I'd say with this review here is that these images aren't real neuromelanin images. They've like doctored them to say this is what it might look like, but they haven't actually done it themselves. So this is normal, but this is them artificially enhancing it. But what they're suggesting is that in psychosis, in certain parts of the midbrain, you might see a hyperintense region because of increased dopamine function, for example. And then there's also been a meta-analysis published again, I think last year, which was specifically looking at the ability to use neuromelanin MRI for people with substance use disorders. And it's quite interesting because it compared the results from neuromelanin MRI studies with post-mortem studies as well, so that actual histopathology. And the results are mixed, I would say. So within the neuromelanin studies in particular, certain substances seem to show an increased dopamine signal or increased neuromelanin deposition. Certain substances seem to show a reduction. Whereas for the post-mortem studies, overall, as you can see, it's quite a wide error bar, so it's not particularly helpful graphic for the post-mortem studies. But basically, it seems to depend on the specific substance and also the demographics of the people that are recruited to the study looking at that substance. Yeah.
I'm so sorry to interrupt. I have a question to ask, and I need to go in.
Yeah, no.
Minutes, so I'll take. Sorry to interrupt. The brain pharmacokinetic of the drugs, very difficult to know because unless you have traces that is sensitive to dynamic changes, but this could be key. So basically, my question is, how sure are we about the time the brain is spending with inactive compounds in it? Example, cannabinoids are incredibly lipophilic. They will gradually go into the membranes and then be released. So the kinetic in the brain of basically THC kind of compounds is much slower than the one in the blood.
Yeah.
You may have still an active occupancy at CB1 weeks after the last dose. These data are very different from each other. Could it be that the postmortem data is obviously seeing the kind of effect of the brain without active drugs? The other ones were measured still presence of the active compound, maybe just a few days after last use.
So yeah, I have looked into this, and for the three main chemsex drugs, it looks like methamphetamine has quote unquote the longest washout period. So we'd be asking people to abstain from either involvement in sex, involvement in chemsex, or use of methamphetamine specifically for 72 hours before. Based on what I've seen, there seems to be evidence that there wouldn't still be significant receptor activity. But also, it's really important to say we're not looking for acute effects. We're looking for the impact of chronic use over time, and that's why I'm looking for people that have used it at least once in the last month and also multiple times in the last 6 months, again as a measure of frequent engagement and recent engagement, so not ex users.
That's really reassuring, but the washout that you mentioned, I think it may be washout in terms of blood clearance.
Fine. Okay.
So the question is really to check what is likely to be the kind of dissociation from the target and any data that would indicate in animals or biochemistry studies to see if you can assume these are basically brain-free, drug-free brains at the time of
absolutely. We can definitely double check that. That's good feedback. Thank you. Cool. Oh yeah, and I just wanted to show you an example from our pilot scan of one of the images that we've obtained. Well done, Ismail, because I think that is very nice. And also on the right-hand side, I just wanted to give you an example of the use of neuromelanin in Parkinson's disease. So you can see on the left-hand side, the control group, and there's a hyperintense region in the midbrain. In somebody with Parkinson's disease, you can see that hyperintensity is somewhat lost. That's just to give you an idea of what the neuromelanin images look like, because I appreciate that's probably the somewhat newer imaging technique. And the thing that I should have said when I introduced it as well, which you've reminded me of, thank you, is neuromelanin is just a standard MRI. We don't have to give people a radioisotope. It's not invasive. And so that's one of the benefits, if it can be used as a proxy for dopamine function over, for example, things like PET-CT and others, which obviously are the only options that we have at the moment for these people. And it means that we can probably start to assess dopaminergic structures in younger people without having to worry about giving them things like radioisotopes. So in summary, I hope I've convinced you that the unique pattern of polysubstance use combined with sexual activity in people involved in chemsex still needs to be robustly characterized using neuroimaging studies. Some of the people involved in chemsex are at high risk of psychosis, overdose, and other mental health conditions, and that, fingers crossed, with this pilot study and subsequent studies, we can improve our understanding of chemsex and hopefully translate that into some interventions of benefit either through harm reduction or direct treatment. Thank you.
No, really interesting stuff, and really to hear what you find at the end of this. Have you got details of the structure of the stop task that you, the task structure of the?
Yeah, what specifically do you want to know?
Well, I'm just like, wondering whether because you can't block trials together, because that wouldn't work, right? So I guess you want to be a bit careful about producing an efficient design. You want to have like some permuted design where you're maximizing the expected variability in the ball response.
Yeah, so being honest, we've stolen a stop signal task that has already worked quite well with a group looking at impulsivity in people living with HIV, which we thought correlated quite well actually. And it's like an arrow task, left, right, and then the sound with the red. I don't know if that's what you're looking for.
Well, it's just that even if you borrow it from another group, like it might be worth just running a few scripts to make sure that you want to make it such that the predictor variable in is maximally variable, and like it's minimized its variance against other things that you don't care about. So I think it might be worth. I've got some scripts for this. This is why I mentioned it. So
okay, sure. Okay, well, we're doing our what is hopefully our final pilot scan on Thursday. It went a little bit wrong last time, being honest, but hopefully on Thursday it goes well, and I can look into that in a little bit more detail.
Yeah. It sounds like you're pretty far along there. So
yeah, well, we are.
Hi, great, thank you. So these people are using a lot of different drugs, and whereas population for this group is 10 people, they're going to vary a lot with what they use, how much they use.
Yeah.
And I was curious how you were going to control for this, because I'm not really sure where it's actually coming from.
Yeah, so it's first of all, it's a pilot study. What we're looking for overall is specific. So the use of drugs, regardless of the drug, is going to have an effect on the dopamine system, right? So we're looking in the first instance at dopamine structures. Secondly, we're interested in how craving and measures of impulsivity might affect their drug-seeking behaviors. That wouldn't necessarily vary that much depending on the substance. But also in the follow-up study, which I hope we can do if we can get funding for it, we'd have more people to be able to, for instance, control for, okay, you've been using methamphetamine for this amount of times in a month for this amount of years. And then like doing a regression analysis for that. I accept that you can't do that with 20 people, but you probably can in the bigger study, and this builds towards that. But obviously we need to put in some thought about how we design the kind of the 3-arm study, because there's lots of different variables, because people are going to have quite a unique, different kind of substance use. But this is just a pilot study to demonstrate that people will come forward, and then we'll have to think a bit more about the design of the subsequent study after.
I was just gonna ask if you more generally about like the wider question you can, I appreciate that this is like very much the start of a line of work.
Yeah.
And you specifically at men who have sex with men.
Yeah.
But if you knew of any kind of like other the wider space of media and it's used.
Yeah, so most of the studies that I've seen have looked at GBMSM. There are some that have done like subgroup analysis comparing GBMSM with trans people. I hope that depending on the results of this, and if we get funding, we can include trans and non-binary people in the analysis for like the 3-arm one that I've suggested. But I just don't think that that's possible in a pilot study of this size at the moment. You've got to kind of control as much as you can, and that's the same reason why we've excluded people living with HIV, because we know that it can be associated with long-term changes in brain structure, possibly impulsivity. But again, in a subsequent follow-up study, I'd like to try and find a way to be able to include them, because there's quite a high proportion of people living with HIV in the Chemsex cohort. And it kind of goes back to the answer to the previous question. We do the pilot study, see how feasible it is, see what we find, and then think about how we can kind of pragmatically design a bigger study that might be better powered to look for some of those more subtle differences between groups within this cohort. I also think the other thing that I should say is I had an asterisk on my slide to remind me to specifically say it about population, but I find the way that we defined the Chemsex population quite strange. And actually, I think that there's probably multiple different subpopulations within it. I think that there's probably like a neurodivergent population. There's like quite a lot of the studies that you look at, there's people that are from quite affluent backgrounds, quite high income. It's like a stereotype of kind of a lawyer in South Kensington starting a Chemsex party at Friday, and then people leave on Monday. And then there's probably a more conventional pattern of like your stereotype of somebody experiencing addiction might be, so from a more deprived socioeconomic background. And I suspect that all of those populations are kind of like within this broader cohort that we're referring to as Chemsex. But because the data is quite rubbish at the moment, we haven't been able to successfully delineate that. And again, that's something that I'd like to try and do. And once you've done that, then you can start to think about kind of the subgroup analysis and power and things to be able to properly look for some of those tendrils.
So I have a question about how you're going to, a tricky issue that I can foresee with the recruitment. So you've got your criteria is that people have to have done it fairly recently and over the last 6 months.
Yeah.
And there is a potential concern that, you know, people who are interested in taking part in this study might actually go and engage in this activity in order to be recruited.
Mm-hmm.
And there's an ethical concern there. And I don't know if you've thought about exactly how you're going to do that so that the participants, maybe you have to not tell them that that's a criteria until after they come forward or something.
I think it's a fair question, but I don't think. I mean, how far do you extrapolate that concern? Like, for people to be involved in a study on cancer, do they go and like deliberately try to ingest things that will cause them to develop a certain type of cancer?
Well, I mean, the people who might come forward to participate might have some motivation to they want to participate because they're interested in getting a brain scan. This is an issue that I don't know if you might have already done your ethics.
Yeah, we have. Yeah.
Okay, good. So I don't know if the ethics committee had. Like, how are you doing recruitment, I guess is the question.
So I'm working, so no, it's a fair question. So I'm working with a charity called Controlling Chemsex, and actually one of the things I forgot to put in my slide is a big shout out to Controlling Chemsex. If you know anybody that is experiencing problems relating to this issue, they're a fantastic charity. But we're working with them for recruitment, and also with lots of the queer venues in Kemp Town, and also some of the queer venues in Soho in London. But I think it's a fair concern, and we can have a think about it.
Yeah. Well, how long are you scanning for? Like, how long are each of the scans that you mentioned? So
How long is the scanning session in total?
Yeah, and each of the. I'm interested in the neuromyelin one.
About 15 minutes long. Yeah.
And the resting state.
8 minutes.
Yeah.
Within an hour. Well,
Yeah.
it went 1 hour and 10 minutes, but it will be.
Yeah.
There's a lot. It's an optimistic pilot. I think,
Is it the multi-echo?
Yes. Yeah, yeah. So for the neuromelanin, it's actually a proboscis echo sequence with a de-optimized TR. So you want to get the T1 effect when representing the iron shortening of T1. You have still the crispness of the TSC and some magnetization transfer effect. So there are two classes of sequences that look at neuromelanin. One is this kind of modified TSC sequence, and one is a magnetization transfer sequence. And they both give decent results. There is even a paper that compares both in Parkinson's, because that's neuromelanin imaging looks mostly. Also in locus coeruleus in different types of disorders, but most of the use is in the substantia nigra in Parkinson's.
Yeah, there's been a couple looking at sleep disorders,
Yeah,
exactly. But I still don't. It's so small. I don't really understand how.
But the TSC approach is just so simple that most groups that do Parkinson's research use it quite robustly.
The magnetization transfer, is it like really susceptible to, is it susceptible to susceptibility? Do you get?
No, so you get on, so if you apply the protocol that looks at magnetization transfer, it's really focused. And this is why we thought that this, even though from the specificity perspective, the mechanism is a little bit more undefined, but I think in terms of the expectation to see something in a case control study and some significant differences, I think the TSC approach is maybe less specific, but more useful.
How are you recruiting your control group? It's like you were saying, people don't turn to Chemsex out of kind of nowhere. They often have like history, like societal kind of pressures and stuff like that. And also potentially they might have a higher risk of mental health conditions. So are you kind of trying to recruit a similar?
So the thing that I didn't mention about neuromelanin is obviously it accumulates over age. So we'll be age matching people, and matching people. We'll be matching people. So we'll be recruiting to the Chemsex half first, and then matching them to controls, but we're recruiting them on the same poster. Actually, if possible, just because of where I can see it going in the future, I could see us creating some kind of task that is like responses to like sexual cues and drug related cues. And for that reason, I'm quite keen to try and match on the basis of sexuality as well, just to make things easier moving forward for this potentially bigger study. I actually started to design one, but James thought it might have been a bit too much for a pilot study. So we went with the stop signal task instead. So for now, they're being recruited on the same poster. I'm trying to match them as well as I can match them. And that's with looking to the future in mind about some of the other things that we might do.
So you have these different drugs and you know roughly for each individual drug what might happen. Do you have hypotheses about specific combinations that might enhance a decrease in some way?
Yeah, I mean, so I think it's kind, you're hypothesizing there, right? Like there's not much, or if anything, out there. So for example, I think the combination of methamphetamine and mephedrone will lead to a really significant dopamine surge. The extent to which that will cause dopaminergic toxicity, I'm less sure. The biphasic effect of GHB on dopamine. So for example, you know, if you read some of the qualitative studies that people do, it's almost like people are running like a pharmacy for themselves. They're like, oh, I did the meth and I started to feel a little bit too up, so I took some G to bring me down, like, or I did some K to try and, like, it's very like out of the back of a car pharmacy kind of vibe. And so I can't really predict it, but again, that's the benefit of a pilot study. Will it have, and that's kind of what my answer was to you before, I presume there will be, because it's two rewarding things, right? It's a substance use pattern and also a behavioral component, but they will both probably converge on the dopaminergic system because that's the main reward pathway, right? So I anticipate changes there. I don't know what they will be per se. And also, again, because it's addiction, craving, impulsivity, I suspect that there will be something relating to that, but I can't say for certain. James, do you have any particular thoughts?
Not really, except that in addictions in general, the dopamine system seems to be reduced in activity, so the feeling receptors are down. I mean, as you can see, even from the post-mortem data, there's quite a wide range, but so I would expect that this kind of overactive overuse of the dopamine system maybe at lower levels if we can detect it with neuromelanin would be amazing.
And it's chicken and egg as well. Like so
Also,
could
neuromelanin does seem to be quite good. It's been compared with F-dopa uptake as well for PET, and seems to correlate quite well. So it seems to be. I mean, it's almost very skeptical about whether it really measures dopamine, but it seems to correlate quite well.
Correlations with trust.
Yeah.
yeah.
Why do you, because it's correlational research, or is that why you?
No, it's people can, for example, you know, the mere fact that it's called neuromelanin MRI is blasphemy in my it does not image neuromelanin. It is a set of physical properties that exist in neuromelanin that gives you this particular contrast, but it doesn't mean that other circumstances within the brain will not produce the same type of contrast. There is nothing in it that is really specific to neuromelanin, but everything else being equal, then changes in neuromelanin content will give rise to changes in signal as seen. It's not like, you know, a PET ligand that is built to be specific to a specific molecule, even though we know that is also not particularly specific necessarily.
Sorry, really interesting talk. And I apologize if I'm rehashing the points that have already been made. I just wanted to check, as you got part of your participant pool are men who have addiction but don't engage in chemsex, am I right?
No, that's so sorry. So for the pilot study, it's GBMSM engaged in chemsex, and then the control group is men who don't use drugs.
No, okay. So would that be for the PhD?
So if James lets me stick around and if we get funding,
Okay.
then I would be proposing. And again, this depends on what the pilot study shows, but logically, to me, scientifically, it makes sense to have some kind of three-arm design with chemsex, non-sexualized drug use, or non-chemsex drug use, and then no drug use. But to be able to do that, particularly with the kinds of various different drug combinations that are going on and over different time periods, you're probably going to need quite a lot of people to be able to power it sufficiently.
I think my question for that was maybe how would you kind of, I guess, how would you form kind of a cutoff, or how would you test with people not engaging in chemsex, as some people may not realize that they've consciously engaged in chemsex? And if they had in the past, would you kind of form a cutoff for that? Let's say if someone had engaged in chemsex 5-10 years ago, would that still be kind of classified as them engaging in it? And currently, would that be involved in the study, or would that kind of not be classified?
Yeah, I think that's a really fair point to think about in the longer term for planning the next one. I have had people reach out to me since we started advertising this, saying, "Oh, I used to do chemsex. Could I be involved?" But now we're very clear it's like active involvement. But I think, you know, depending on what we show and depending on if this still continues to be a problem, there probably is an argument there for looking at historic use. Again, if you put that in and you include those people, though, you're going to need to have even more people because. Yeah, exactly. But no, it's a really good point and something that we would need to consider. Yeah.
Have you thought about doing, because you talked about this, the stop signal task, measuring response inhibition in these participants, but you could potentially do that as a behavioural study and have like much larger samples, and it's much more easy to conduct, and you can have all of your control groups, and you know, this is an understudied population, so you might find that you get the response inhibition deficits in these populations in a larger behavioural sample, and you could potentially run this alongside, and that would also justify, you know, your PhD plans and imaging plans.
Thank you. We'll write it down.
I think the issue with running a really big study for a PhD is the expense. So doing some out of scanner work is very, very, very likely.
I did in my interview with James, I did say I'm very keen to learn neuroimaging, and to be fair, it's putting me through my paces. But
That was a wonderful talk. Thank you very much, and thank you all for coming.